Hi, this is Dr. Lenora Coleman, president and founder of Healing Our Village and Total Lifestyle Change, which is my nonprofit. And as you know, on Wednesdays and Saturdays, we usually come to you with some type of really critical information. This is our show called For Your Health. And as you know, February is Heart Month. So this month we've been streaming live with some of the top experts throughout the country on heart disease. We've talked about hypertension. We've talked about peripheral artery disease. And this today and this coming Saturday, we're going to continue with talking about heart disease. Today, we're going to be talking about heart failure. And we are honored to have my friend and colleague who I have done work with over the years. I'm really, really honored to have him here today with me. His name is Dr. David Smith. Dr. Smith is in Charlotte, North Carolina. So, all you Charlotte folks, I'm giving a shout out to you. And thank you so much for tuning in today. And Dr. Smith, I can see you're there. You're smiling. How's everything going down there in Charlotte?
Today is one of the best days we've had in a long time. It's about 65, 70 degrees out here.
Yeah, I know.
You should probably come down.
Yeah, I know. I am. I'm coming. I'm coming. I'm coming. I love the food in Charlotte, and give me a chance to see you and check out your fabulous clinic and practice that you have down there. This
Welcome.
heart failure is a topic that is important, and you know why it's important because it's still the number one DRG of people
Hmm.
going into the hospital. You would
Oh,
think by
yeah.
2021 we would have figured this thing out.
Well, I actually don't. I think what's been happening over the years, and I'm an old guy. So what's been happening over the years is the definition and the diagnosis has been changing, right? First, heart failure was just, hey, well, your heart's just not doing what we want it to do. And then it then became, well, now there's a squeezing function versus a non-squeezing function. And the definition has changed so much and the medications have changed so much. And then we're always trying to improve on the last thing. So I don't really know if we'll ever get to a point where it's just great. We're just safe and we can't go any further, especially as you mentioned, the DRG. I mean, everyone comes in for heart failure. And if there's one thing we cannot control with heart failure, it's how people with heart failure act, how they manage, how they control themselves. And that's always going to put them back in the hospital.
Yep. So we're here today. We're going to answer all the questions that people out there may have
Good.
about heart failure. Try to help them do a lot better job at managing and controlling it because, as you mentioned, and we'll talk about it, there's a lot of drugs that weren't here 10, 15, 20 years ago that we now have available to us. So, but before we jump into the nitty gritty of treatment, let's talk a little bit about what exactly is heart failure. Can you just sort of tell the audience what that is exactly?
Good question. Depends on who you ask, right? The traditional way that we all learned it was from a guy, Eugene Braunwald. Trained at Harvard, worked at Harvard, but his way of actually describing it was it's the heart's inability to either eject the blood that you need when you need it, or inability to accept the blood you need back from the system, right? Another way to put it honestly is your heart's just not doing and keeping up with the activity level and the exertion that you need. So if it can't pump out enough appropriately, then you're not going to get the blood going everywhere it needs to go, and you're going to be tired, fatigued, etc. But if it can't suck blood back from the body, from the system, the way you need it to, then you're just gonna all that blood is gonna be congesting, everything before it. So, your legs, everything that's supposed to put blood back into your heart is gonna go backwards.
Right. So, because your heart is sort of failing to pump, it's not getting the blood back out or back in
Mhm.
correctly, it causes
Mhm.
symptoms. So, when people come and they present to you, what are the typical things you hear them say that makes you start to think, maybe we better look at their heart?
Yeah, no, yeah. It's funny because, a lot of times symptoms have been going on for a while and they don't know it. You may have some people who are, just more and more fatigued. They're just tired and noticing that, hey, going upstairs is a little bit harder than usual. And they just say, oh, I'm getting old. or hey, I'm just out of shape, and they don't do anything for years. Well, that actually could be part of the heart failure, just from the definition we just talked about, heart not being able to pump forward. A lot of times the congesting will just be there. People just build up a lot more fluid. They say, oh, well, I'm just gaining weight, or hey, I'm eating more. Other times they'll say, hey, I'm not eating more and I'm just gaining weight. I don't know what's going on. I'm saying these things because I bet you a lot of the listeners have heard these,
Yeah.
same sayings over and over, probably said it over and over. But it turns out that that could have actually just have been the congestion that could be building up. Legs swelling, some people coughing, some people going to sleep and gasping for air in the middle of the night, just or anything, or not being able to lay down flat on a bed, just needing two or three pillows to prop themselves up. All those things are signs of congestion.
Yeah,
And,
yeah.
like I said, they've been going on for a while before people ever really pay attention to it.
One of the things that I noticed when I was working in the clinic is the thing that brought a lot of people in, especially women, is they couldn't get in their fancy shoes because their feet had swollen, right? So swollen feet, swollen ankles. That's what brings folks in, and they have no idea that it has, because it's down in their feet. They have no idea that it has to do with their heart, right? And so that's another symptom that I used to see people come in and say, I think I might have sprung my ankle, or maybe I twisted something because all of a sudden my ankles are swollen and won't go down. So that's another one of those symptoms. So when we talk about how many people actually have heart failure, we're at about maybe 5 million Americans actually have a diagnosis of heart failure. 550,000 cases every year. All right, because of heart failure. So when I say it's the number one diagnosis related group, or DRG, that brings people to the hospital, that is in fact true. So there are certain groups that are at a higher risk for heart failure. So what are those groups that you see mostly?
Hello? Back.
What are the groups that you see mostly that tend to have a higher risk for heart failure?
Sorry for a second there. I started freezing, but thank you for repeating the question.
No, no
That helps
problem.
out. So it actually looks like there's a gradation. If someone was to ask me, hey, you know, who gets heart failure in the younger years? Well, I would say black men. If you're going to ask me lifetime risk, I'll say black people totally. If you give me, percentage wise, I'll say 25% of white people over their lifetime will get heart failure. That's one out of four. Whereas black, 33%, one out of every three blacks will get it. And it's interesting. It's actually a grade. If you look at some of the data over the past, I would say 10 years or so, it turns out that Asian populations tend to be the lowest risk for heart failure. And then, we can kind of split it up a little bit by race and a little bit by sex. If you take the average white American female who's going to get heart failure, you double their risk, and then you have a white man. Add another 30%, now you have the black female's risk of getting heart failure. So higher than white men or white women. But then you add another 10, 20%, then you got the black man.
Okay.
So yeah, the ones
Yeah.
we typically see are black patients. And if you really get into it a little bit more, turns out it's mostly related to high blood pressure.
Right.
Yeah, there's almost never a case that you'll get heart failure unless it's something genetic, or they were born where the heart's just not functioning right. There's almost never a time that you don't get high blood pressure as part of the syndrome in heart failure.
Right, right. And the thing that, as you know, I have a Stop Hypertension initiative.
Yes.
I launched it last year, and this year, 2021, we're starting again, trying to get people to know their numbers. And it just shocks me that people are
Mhm.
walking around here with blood pressures of 160, 170, 180,
Yes.
over 100, 110.
Hmm.
And they come and they see me and they say, hey, doc, can you take my pressure? I'm not feeling good today. And I take their pressures, and it's like, oh my God, how are you
Hmm.
walking
Hmm.
around with pressures that high? But it happened. I mean, it's just amazing to me how high a pressure
Yeah.
can be, and people, don't have any symptoms.
What kills me about that too? Um, you know, a lot of times we make excuses for that in a lot of our communities. It's like, hey, well, my grandmother, my grandfather had high blood pressure. They lived to be 90. They can do it.
Right.
Other people are like, well, it's there, but I don't feel bad. Well, in my mind, if you don't feel bad, that's worse, right? Because if
Yeah.
something really hurts you right away, you feel it.
Right.
But think about it, high blood pressure, hypertension, that's a silent killer. It doesn't
Right.
hurt you until it hurts you, right?
Yeah.
It will cause a stroke, it will cause heart failure. So the fact that you have this high blood pressure and you don't feel it, to me suggests that it's been there so long that your body's gotten used to it. You think that is normal, although it's not. Your heart is, reaping the benefits where, I say that in quotes, it's not really a benefit, but your heart is ailing from it. Your brain is ailing from it. Your kidneys are ailing from it. And it's not until it actually hurts you that you actually pay attention to it.
Right.
So you're right.
Right.
You're going to see a lot of people walking around. You know what? With your program, if you can get people to treat their high blood pressure better, you probably can single-handedly reduce heart failure better than any of the medications we have out right now.
Exactly. Exactly.
Yeah.
Exactly. If
And
they
that's
know
not
their
even an
numbers
overstatement.
and know that their goal, what their numbers should be, right? So, as you
Yeah.
know, the guidelines changed a year or so ago. So it used to be 140 over 90 was where we used to get worried, and now the new number is 130. The top number is 130. The bottom number is 80. So 130
Hmm.
over 80. But the reality is for African Americans, and I tell people this all the time. When I went to Africa and I went to Kenya, and we went out and did some work with the Maasai tribe out there. Their blood pressure was 90 over 60. So
Oh,
we,
goodness.
as a people, genetically don't necessarily supposed to have high blood pressure. So this is more of a westernization, or part of the colonization that has got us to where we are because of they talk about the inside passage and that boat ride for 3 months.
Hmm.
And so everybody who landed on the shores, wherever the boat landed, so
Hmm.
Jamaica, the other parts of the Caribbean, Europe,
Yeah.
United States of America, wherever that boat landed, those people had to retain salt and had to retain water to make the
Oh, yeah.
voyage. And so that's why you see these higher pressures in people who are in these other places, right?
There's no question about that. That's a hormonal change that we've noticed over the years. Getting nerdy, they call it RAS, RAAS. But that whole system is designed, and this is interesting. That system is designed in us to retain salt, as you said, salt and water, so we don't, pass out, get dehydrated, and such. Well, it turns out that that system can be working in overdrive, right?
Right.
That system is also kicked into gear by, stress, by salt, right? Like you did, multifactorial is what we're going to say. A whole bunch of different factors. Poor sleep can hurt us. Just dealing with psychosocial issues, social determinants of health, where we're worried about our next job, our next life. How are people doing? How's the family doing? I mean, there's so many different things that will just increase our stress levels. Then of course you got what we're breathing in, and we can go on and on. But I can come up with a litany of reasons why our blood pressures are so much higher than our brothers across seas.
Yeah, exactly. And so, I think that one of the, and as you know, I've been doing healthcare disparities and chronic disease management for over 40 years.
Oh
And
yeah.
the thing that's so interesting to me is we had this COVID-19, and now all of a sudden everybody is talking about, the disproportionate number of African Americans, right, who are dying of COVID-19 complications, right, and they have a worser outcome. And I'm saying,
Mhm.
hello, folks. Okay, this stuff's been going on since I've got out of pharmacy school, 30, 40 years ago. But
Yeah.
whatever helps to sort of shine a light on this thing. But it's because of the
Yeah.
diabetes and the hypertension. It's why the COVID-19 cases are higher in our community, and so it
Hmm.
goes right back to the hypertension. But then you talked about the social determinants, right? So who
Yes.
lost
Yes.
their jobs? Right?
Right.
Who didn't
Right.
have daycare, so they had to stay home and teach their kids? Who live in single parent households? Who
Hmm.
didn't have that extra little money in the bank to be able to make it through? I mean, if you like Texas, right? Who do you
Right.
think doesn't have water? I saw folks out there digging up ice to make water in Texas, all right?
Yeah. Yeah.
It always comes back to these socioeconomic issues where we
Yeah,
are already always predisposed and have a higher risk, more stress and more strain, right? In our lives than in the lives of people who don't necessarily look like me. And so that's an
absolutely.
issue. And so because of that, we got to be super healthy, right?
Right, and absolutely, and you also can't discount some of the other things medically. We tell people, COVID, for example, those who tend to have a higher likelihood of dying from COVID infections tend to be those who are hypertensive, diabetic, kidney disease, smoking with asthma or COPD, and really overweight. Well, guess what? All of those are really higher, more rampant in African American communities, right? Black communities. Forgive me because I often use African American and Black almost interchangeably. Like
Yeah.
I'm Jamaican American, but I don't want to be left out of the conversation. So African American and Black. But yeah, I mean, those are higher in our communities, our societies, and then that marries in exactly to everything you just said. You hit them all. You add those things to a person who has to make a decision. Listen, am I going to buy this medication, or am I going to be able to put shoes on my kid's feet, or am I going to pay the electric bill? Or, those are real discussions that never really pop up in the media. But what you will see in the media is African American communities more likely to die from XYZ. Then you have a fear factor and nothing you can do with it, because even if there is equal access to care, which there isn't, you're not going to have the same doctors, the same resources, the same hospitals, the same money, et cetera, in the same communities. But even if there was to be a place where there's equal access to care, the equity is not there. We're not
No.
starting from the same spot,
Nope.
right? We're starting from below. If we got, the equity, then the equality may make a bit, of a difference, a much better outcome at least.
Yeah. Yeah. It's
Yep.
interesting. So a real short story. So my brother had hypertension for years. And when he was decided that he was getting ready to retire early, and so in order to be able to get the highest amount he could on his retirement, he started working 60-hour, 70-hour work weeks because they
Hmm.
paid you off on your pension for your best and highest year.
Hmm.
So I kept telling him, Walter, you need to, you need to relax. You're working too hard. Your blood pressure's high. You're not doing it. And he says, well, my doctor says my blood pressure's just fine for me. I said, Walter, there's no just fine for me. There's a number that your blood pressure is supposed to be at,
Yeah.
and then your number is too high. So anyway, short
Yeah.
story, he has a stroke. He ends up retiring early because of the stroke.
Mm.
And come to find out, he doesn't have high blood pressure anymore. You know why? Because he doesn't work anymore. So when we went back and started looking at all the stress and strain of his job and the
Yeah.
racism and the unequal treatment at his job and just the
Absolutely.
pressure he felt, whether it was there or not, is irregardless. It's your perception of what's going on
Hmm.
in your
Hmm.
life. So now his blood pressure, I mean, he's on nothing for his blood pressure. It went away.
Oh my gosh. Yeah.
So
I'm,
just
I'm
think of
totally
how
not
many people
surprised.
like that are out there because then don't realize that that's what's happening.
Probably almost every one of us.
Yeah.
You're
Oh,
right. And
listen.
and then when you get out, you change the way you act, you change the way you sleep, you breathe, you wake up when you want, you actually breathe more, you can actually relax the tension around your neck. There are a lot of studies, and actually even if you ask the chiropractic community, they'll talk about this all the time. Stress and tension around the neck. Especially if you're lifting and doing manual work and you actually have neck strain and neck stress, that is actually a direct link to hypertension. I didn't
Wow.
know. I was learning this recently. So what they do a lot of times is if you can relax the stress in your shoulders, maybe even do some manipulation, maybe some neck stretching, you can actually reduce blood pressure just by that alone.
Wow. See
We
that?
do some of
See,
that in my
tidbit. I
practice.
didn't know that. Okay, I love these tidbits.
It's beautiful
All
stuff.
right, so now let's talk about the medications for heart failure. So we've had
Ooh.
some newer agents that have come out over the last 5 to 10 years. I wanted to go through all the different drugs because we probably have a lot of people taking different things.
Oh
So
yeah.
I thought we could just kind of go through them one by one. We could start off with beta
Sure.
blockers, right? So
Sure.
tell me what they are, how they work, and which ones you think, what the names of them are that you see in your practice, and the side effects from those agents.
That's funny that you're saying this. Do people know that you're one of the world's most authority leaders in any of these drugs that we're talking about? That's just amazing. So we'll do this together.
Yes, yes,
Yeah.
exactly.
So some of the background is this. So for heart failure, a lot of different things that normally are supposed to happen just go awry. Kind of like what you were talking about, the salt retention and the stress hormones, et cetera. Well, if you really divide it into two kind of mechanisms, yeah, on one end, it's those kind of stress hormones and such. We'll call it the RAS again, the RAAS system, and we'll talk about that. But then the other half is kind of an adrenaline surge. You got to imagine if, again, your heart is filling up with too much blood and backing up, or just not getting blood out the first way, you have a big surge of adrenaline. Hey, I got to get this blood out. What's going on? And that big surge, actually, when it works on the heart, is supposed to make the heart go faster.
Right.
Well, going faster on a failing heart is not actually going to help you.
No.
So we actually stop some of that adrenaline surge on the heart by stopping these receptors in the heart. We call them alpha receptors, beta receptors, even gamma receptors, but different alpha 1, alpha 2. Any way you put it, irrespective of the letters, by blocking some of that adrenaline on the heart, you allow the heart to slow down its function, which then allows it to fill with more blood. So that way, when it does contract, it is getting out a bigger, what we call stroke volume.
Right.
And by doing so, you get less of a stress and strain on the heart, that you don't get as much fiber formation. And the heart is pretty interesting. It's like a string, or like, I don't know if you ever played with a slinky.
Yeah.
But you pull it out and then it comes back. Well, the
Right.
heart has that sort of function to a certain degree. You pull it out and it comes back. So slowing everything down with the beta blocker, blocking the adrenaline, the heart has a better chance of actually recovering function, if it will recover function at all.
Right, exactly. So the drugs that I see out there are your carvedilol, your
Hmm.
metoprolol. So those are some of the couple of the common ones. They usually end in the law, LOL, right? Those are
Yeah,
the generic names.
exactly.
And then side effects. What are your patients usually complain
Yeah.
of?
So when you talk about the different beta blockers, they are different. I know I said beta blocker one, two, and all the rest of that kind of stuff. Some of the beta blockers just work on beta one, and that's really just in the heart. Some of them work on beta one and beta two, which is really not selective for the heart. And for those people, the beta 2 is really more so in the lungs, so you can actually get a little bit of wheezing. People with asthma, COPD can get some exacerbation if you don't use a selective one. Sometimes people have them with alpha and beta drugs. The carvedilol that you talked about, another one's labetalol. They have, alpha and beta activity. So, blood pressure can change as well as slowing down the heart rate. So you can get some lightheadedness, dizziness, fatigue. There's some beta blockers like the older olols, the propanolol, metoprolol. Well, not so much metoprolol, but any of the other olols. If they get through the blood-brain barrier or close to the brain, and they slow down that adrenaline in your brain, you can imagine you're going to have a little bit of depression, or sluggish thinking, or
Right.
vague thinking, or any of those kind of things. Yeah. So those are
Yeah.
usually the side effects. But a big one for men, it can even cause erectile dysfunction in a lot of men. So, there are a lot of things we have to think about. Again, maybe not always talked about in our communities, because people are going to say, oh, well, I'm just not interested, or maybe it's just a heart or something. Well, it can actually be your medication too.
Exactly.
Double-edged sword.
Exactly,
Yeah.
exactly. So yeah, I tell you, when as you know, I do a lot of diabetes education. When I want to get my male
Hmm.
patients' attention, I start talking about erectile dysfunction, and then they
Oh,
they
yeah.
sit forward in their chair and they start really listening to what I'm trying to tell them. And so
Hmm.
that's in fact very true. ACE inhibitors, that's the next class that I think is commonly used in the management of heart failure. That's your prills. So lisinopril, captopril,
Real.
ramipril, those are the prills.
Yeah,
So
now
how do they
pro.
work?
Yeah.
You talked about that
Yeah.
RAS, RAS, the RAS system.
Yep.
So I think
I
that
love
kind of
that.
goes hand in hand, right? Yeah.
Definitely does. So let's go to medical school for a quick second, right?
Okay.
So it's really kind of cool. Well, when your body is not getting enough blood out of the heart, Most of the blood actually goes to the kidney, so the next to the brain. So your kidney's actually in charge of regulating the salt and the water, right, in your bodies. So if you get enough fluid, get enough salt, you keep the fluid in, and you get enough pressure, et cetera, et cetera. Well, if the kidney senses less pressure, it gets mad. It wants to retain the fluid and not pee it out. So what it does is it starts releasing one protein, it's called renin, and that actually goes to the liver to tell another protein there, hey, angiotensinogen, another protein that you need to be active. That other protein gets to the lungs and tells the lungs, hey, you need to be active. And it changed this thing, angiotensin 1 to something called angiotensin 2. Angio is for blood, tensin tightens. So it tightens the blood vessels. So your pressure in the blood vessels go higher.
Right.
That should happen. And then when it gets over to the adrenal gland, pretty crazy, right? This is big hormonal kind of milieu of stuff. But then it gets to the adrenal gland and then it releases something else called aldosterone or aldosterone, right? And that goes back to your kidney and tells it, hey, keep more salt in and stop putting out, more
Right.
water. And at the same time, the angiotensin part goes to the kidney and tenses the angio or cuts down the arteries, right?
Yeah.
And so at the end of that, it does cut down the fluid even more. So think about that. If you're cutting down the fluid more to the kidneys, and the kidneys set this all up because it wasn't having enough fluid, so you make angiotensin that cuts down the fluid more, but the kidney sense less. So you keep going back. In
Yeah.
other words, we're making a big circle. And
A
so
big, a vicious circle. Yes.
while that vicious cycle, called the RAS cycle, works well acutely for now, hey, I need to keep some salt water on because it's hot out or I'm going to pass out or such. If that keeps happening, it's going to kill the circulatory system. And so
Exactly.
what we do is we try to block that. We jump somewhere in the cycle. And if you jump into, right where I told you angiotensin 1 is formed, the first angiotensin tightening, if we can block that formation, we think you're not going to get that overactive response, the
Right.
deleterious response. So that's what the ACE inhibitors do. They block that change of angiotensin 1 to angiotensin 2 because angiotensin 2 works, so much better. Well, the problem there is if you block that conversion, angiotensin 1 just stays there and kind of builds up and such. And especially in black people, you get side effects or I'm sorry, byproducts of angiotensin 1, breakdown to angiotensin 2. And those things kind of make you cough. They can even cause your tongue to swell, your lips to swell, and you can get allergic reactions to it. So there's definitely a limitation as to what you can and can't use, especially in certain types of communities more so than others. Then another portion or another part of the ACE inhibitor is, and ACE is the enzyme that makes angiotensin 1 go to 2. That angiotensin can, when it goes to the liver, actually, I'm sorry, the kidney, once it goes to the kidney, it's interesting what it does. Your potassium levels can actually start increasing.
Right.
And when your potassium level increases, then you have a whole bunch of other disarray, a whole bunch of other effects, right? Your potassium level now causes your heart to start skipping beat. And oh, by the way, the heart was a problem in the first place.
Right.
So
Exactly.
they're very scary.
Yeah,
So
it is. It
that
is.
said, by blocking that circulatory pathway, however, people do tend to do much better.
Right.
They had studies on this for decades, where if your heart function is down, not so much if your function is normal and you have heart failure, because that's still possible, but if your function is down, we know if you put these ACE inhibitors on, people get a much better chance of surviving. If they're in a hospital, stay out of the hospital. If you're not in a hospital, cut down your chances of going into the hospital in the first
Right.
place. And knowing that, a black person going into a hospital compared to a white counterpart has a 50% chance of surviving or even making it out of the hospital, relatively speaking, and twice the likelihood of dying in the next 5 to 6 years compared to a white counterpart. Well, the ACE inhibitors cut that down dramatically as well.
Right. Right.
It
Exactly.
used to
And
be that if you had heart failure, we would think that you have about half of the people with heart failure would survive past 5 years.
right.
That number's better now. We don't have the real numbers, but most of that is attributed to these ACE inhibitors blocking
Yeah,
that
and then
cycle I'm
if
talking
you
about.
mentioned cough, so sometimes because of the cough, they try
Hmm.
a sort of an associate class of medicines called the angiotensin receptor blockers. So I guess
Yeah.
the most common one I see out there is losartan. Is a lot of people are on that particular one. So they work pretty much similar to the ACE inhibitors.
They do. The good news is that cough happens when you go from the angiotensin 1, the first one, to the angiotensin 2, which is much more potent, the second one. If you let that system happen, then you're not going to get those byproducts that cause the cough. You can let them do that all they want. What's going to happen is you're still going to block the pathway, that circulatory system, by bypassing all that. And then even though you make the angiotensin, it's not going to matter because you block it. That's why you have an angiotensin receptor blocker. The
Right.
ARBs is what you're talking about. So this goes right to the organ and tells the arteries themselves, hey, relax. You don't need to tighten up that much. Calm down
Calm
to
down.
block that
Exactly.
circulatory system. Yeah. And you said losartan. That's out there. Turns out mostly in cardiology and mostly because of the newer studies, people are using a lot more valsartan.
Okay.
Um, yeah, and it really is, not going to matter which one. It actually turns out to be more of a formulary discussion in real
Right.
world medicine. Which one does your insurance, cover more so than the others? And that does have its own set of problems with different communities having different insurance by different employers, et cetera, et cetera. That's a whole different discussion if you want. But yeah, that tends to be the biggest thing. What can the person afford?
Yeah.
But any of
And
the
then now
artans,
on the
like you're
market
saying,
we have some combination products. So
oh yeah.
Entresto is the brand name of one of the combos that are out there that you probably see on the commercials, right? There's a lot of
Oh
commercials
yeah,
because it's a relatively
yeah,
newer drug, so it's still being has a brand name instead of only generic. So
yes,
that's a combination of two drugs, right? So the valsartan that you
absolutely.
mentioned is in that combo.
Yeah, exactly. And that's just the ease of things. That's a lot of why people go to valsartan also, more so than olmesartan, candesartan, losartan, and all the other artans out there, right? Because valsartan, we know, hey, if that works, you can actually really just convert it to this valsartan sacubitril, which is a combination of valsartan being one, sacubitril being another, and that's called Entresto.
Right.
That's that big Novartis drug that everybody's seeing on commercials. We actually have people coming in and say, "Hey, can I get that new heart failure medicine? It looks really
Right.
good," and it does a lot. Um, that actually came out in a study published in 2016, New England Journal of Medicine. It's pretty interesting. They had 9,000 people from around the world, different countries, and they brought them all in, and it's only in people whose heart function is down, less than 40%, really 35% or lower. If you gave them this combination, valsartan plus the other drug, sacubitril, and compare that to people who just had valsartan alone, the people with the combination had a much lower chance of dying and heart, hospitalization as well. That's typically what we look at in cardiology and heart failure. Are you going to die, or are you more or less likely to be hospitalized? Those are the main things. After that, okay, so how is your
So I think that that's so important that a lot of times some of the formularies don't really allow you to have this these combination products. But if you have yeah, clinical studies that actually show that, then that can definitely be a problem. You mentioned something that I think is really important, and actually you said a few minutes ago that when African Americans go into the hospital, sometimes they don't come out of the hospital. So, people used to think that, the reason why African Americans didn't go to the hospital was because of their chances of not, getting out of the hospital was, they were dying there. But that's actually true. It's not a myth. So this 50% of people who go into the hospital not coming out because of heart failure. And so when you talked about that, Entresto and the data actually showing that, yes, in fact, it decreases hospitalization. That's a big deal, especially when you have 9,000 patients. So now you can sort of trust the data that there was enough patients in that particular study to trust the data that came from that study.
Oh, no question, no question. Sorry, I had a freeze also on the computer, but I'm around it. I'm back.
Okay, yeah,
Um,
no problem. I mean, I can
but
tell when you freeze, so I just kind of am filling in the blanks until I can see you come back to me. So I'm a talker, as you know, so
no
I'm good at
problem.
filling in the blanks.
I hope that means you're
Absolutely.
not seeing my
Um,
face just freeze like that.
I
But
know. Go
but I can
ahead.
tell you also one more thing about that is you know we some of us in cardiology have problems with that particular study, right? Yeah, the study showed it's a benefit. Yeah, great. Novartis took off and it's on the news. It's some people say it's so good it should be in the water. Totally understand. But a couple things. One, if you have allergies to the drug, you can't try it. The problem is you never know you had allergies until you try it,
Right.
right? So it's kind of circular. But, you know, that study that I mentioned had over 9,000 people in there, multiple different studies. However, if you look at them, there are only 400 Black patients out of the 9,000 in the entire trial.
Right.
Now, here's the other thing. That study was across the world. Out of those 400 Black patients, almost none of them were in America. So how do you generalize that to Black patients, African American patients? I don't know if you can. Are we going to get the same outcome, the same benefits? I don't know. Should we do that before other drugs that we know work just as well, if not better? I don't know. And then the last thing I'll say about that is even if you look at those 400 out of 9,000 Black patients, they were 5 times more likely to get that stuff I talked about, the swelling tongue, we call it angioedema, or the cough, or those comes from the byproduct. So honestly, although Entresto is great, your doctor may decide or may have this open conversation, hopefully open conversation like we do, but an open conversation with you that it may not be the best thing to jump to right away. That there may be another one that I'm pretty sure you're going to get to. There are other types of drugs in combination that work very well, especially in African American communities.
Right. So you're probably alluding to they called it the black drug, and that was I actually was worked with that company when that drug first launched on the market, and it was Bidil, which is a combination product. It actually showed a 48% reduction in death, okay, from heart disease in patients with heart failure. The hospitalization data was amazing. But for whatever reason, and I know because I was out here trying to get people to put this drug on the formulary, for whatever reason, we had a hard time getting people, not only the hospitals and the health plans to add it to the formulary, but we had a hard time getting some cardiologists in the country to even use that drug. Yeah. So that is definitely something that is, so it's still out there. If your doctor mentions it to you, I think it's important for you to feel comfortable. The data on the drug is amazing. The actual studies on the combination Bidil was actually done in African American cardiologists throughout the country. And so these were some of the leading black cardiologists in the country did those clinical studies on Bidil. So the data from the study was actually published in the New England Journal of Medicine. So yes, that combination, and actually if you read the guidelines for the management of heart failure, where they actually tell you the pros and the cons of the different drugs and which drugs they think you should use as first line, second line, third line drugs, you'll see that in fact Bidil is recommended for use in African Americans that have heart failure. And it's got some older drugs in it. It's got two agents, isosorbide dinitrate and hydralazine. And there were some smaller studies done early on, 20 years ago, that showed that these agents, when put together, actually had a benefit. But the problem is that you had to take 14 to 18 tablets a day to be able to get to the dosage that you needed. But when they put it together as a combination, they were able to find that was a much better combination. So what we're going to do at this point is we're going to give you guys a stretch break and let you stand up. We're going to show you a new product that's going to be coming to the market very soon. It's called Handout. And so we're going to have you take a break, and then we'll come right back and finish up with our segment today on heart failure with Dr. David Smith.
Epigallocatechin gallate, superoxide dismutase, glutathione peroxidase. Now, those are names you probably aren't familiar with, but you should be. Those are antioxidants known to fight free radicals. In fact, did you know that some viruses are actually alcohol resistant? One major study showed that by adding the epigallocatechins from green tea, it killed the virus on contact. Please allow me to introduce myself. My name is Mark Johnson. I'm here to share with you an exciting new, technologically advanced, patent-pending green tea hand sanitizing wash from Handout Protection. Now, this is not your typical hand gel designed to just smear all over your hand. This is a hand washing sanitizer to cover your entire hand, both the front and back of your hand, in between your fingers and your wrist. This is a non-sticky sanitizing hand wash designed for convenience to take with you in your purse, pocket, or carry in your lunchbox. As Dr. Josh Ridge has stated, what goes on your body goes into your body. That is why we choose only the highest FDA-compliant ingredients, such as 75% isopropyl alcohol and organic green tea brewed with alkaline water. The only way to protect yourself and your family is to always carry a disposable package of Handout with you. This may be the only handout you ever need.
Well, welcome back. You are watching For Your Health. This is our heart failure episode that we're doing because, as you know, February is Heart Month. So thanks for coming back. We are here and privileged to have Dr. David Smith, for those who are just now joining and looking at the show. He is a cardiologist out of North Carolina, and we've been talking about heart failure. This will actually be up on our website, HOVhealth.com, as well as available to you on our YouTube channel. So you'll be able to see for those who just tuned in, you'll be able to see the whole program. So Dr. Smith, we were talking about medications and treatments for the management of heart failure. So we covered the beta blockers, we covered the ACE inhibitors, we covered the angiotensin receptor blockers. We talked a little bit about some of the combination products, Entresto and Bidil. So now we're going to talk about the aldosterone antagonist. Spironolactone is an old one. Eplerenone is a little bit more recent, and there's a new one coming on the horizon. So tell our audience how these aldosterone antagonists actually work for the management of heart failure.
Oh, absolutely. Excellent. We don't like the RAS system in cardiology. We can't stand it, honestly. So we do whatever we can to kill it as much as we can. So that whole RAS system with the ACE inhibitor, and then we block that, and then you have the ARB, and then we block that. Well, if any of it does escape and get over to the adrenal gland makes aldosterone. Well, the aldosterone goes to the kidney and still retains a lot of that salt water. It's annoying, but it also causes fibrosis and all the rest of the stuff. So we try to block that too. So we block almost every single stage of that RAS system.
Yes.
And it turns out when you block that too, you still do get a further reduction in hospitalization in people with heart failure. So we add that on. The couple of points about that is when it gets to that point of the kidney usually is peeing out a lot of potassium. But if you block it, then the kidney starts retaining all that potassium, and retaining all that potassium can become a problem for your heart, even the heart rhythm and such. It's actually dangerous. It's a lethal, and it's what they get for lethal injections, right? But the other part about it is aldosterone, the prototype, as you mentioned, these things are all hormones, right? And aldosterone looks a lot like steroids, and they actually they can actually go and kind of worsen breast tissue, if you will. It can cause some pain around the nipple, around the areola, even in men. So then they switch to eplerenone, which is less likely to do that and has the same outcomes, but you can still get a little bit of, we call it gynecomastia, right? Well, Bayer came out with another one called finerenone, newer drug, same kind of effects, works well even with kidney failure, to degrees of kidney failure, but it actually has less of that gynecomastia effect, mostly because it's kind of a partial drug. Like, it doesn't bind and just stick on the receptors as much. It goes on and off, so you don't really have time to have a lot of problems.
Okay, all right. So this drug actually is coming. It's going to hopefully be here in the next few months. And, for a lot of, I know men especially, that gynecomastia is really an issue. And so this I think, is going to help us in terms of getting our patients who need that extra little bit of addition, because they're already on some of the other drugs and they're still not where they need to be. We're looking forward to this new agent that's coming on the market this year. And then there's an old drug that, digoxin, right, which has been around a long
Oh, wow.
time. It's
Yeah.
actually a natural product. It comes from a plant, foxglove, and
Yeah.
they used to use it a lot back in the day before they had some of the newer agents. So, talk a little bit about
hmm
how digoxin works and when you use it in some of your patients.
Sadly enough, it's not used much anymore. In cardiology, it's fallen by the wayside dramatically. Again, mostly because of these other agents, as you pointed out, have such dramatic effects. They used to call it dropsy back in the days, right? Where they used the foxglove plant and used it and said, hey, people do better. Well, it turns out that you don't actually live longer with digoxin, and people don't actually always feel better. There's some vague reports about you being able to exercise a little bit better with digoxin. The best thing we have is you're slightly less likely to be in the hospital with digoxin, but because it doesn't cause all the other benefits, if you go back to what you said, a patient with heart failure is taking beta blocker, ACE inhibitor, or ARB, aldosterone, or Entresto.
Yeah.
Maybe they're taking, yeah, Bidil on top of that in certain situations. There's yet another drug called Ivabradine or Corlinor that some people want to add on to everything else. If your heart rate's over 70, because we know you drop your heart rate down, you live better. And then to throw the Joxin on, where you know I mean, you're the expert of this. And most of the times, people have diabetes on top of this, so
Right.
then they're taking insulin,
Yeah.
GLP-1, GLT, well, all these other
So
drugs.
many
People are
drugs.
just not going to take them. And
Yes.
so that, in perspective, a lot of times with digoxin, we almost never use it unless we have no other option, or if a patient is actually in the hospital and their heart rate's going crazy in a rhythm we call atrial fibrillation and they have heart failure, sometimes we'll just give a little bit of digoxin, not anticipating they'll be on it for a long time, and never using it at high doses in people with renal failure because it builds up in the system and causes toxicity. But I think
Exactly.
what you did is you've nicely laid out all the drugs that our community, everybody should be talking about, the beta blockers, the ACE, the ARBs. Those are, and the aldosterone, the Bidil, especially things that they have to be talking to their doctors about in detail, because those are the mainstays. Those are the baselines. You have to have that discussion. Things like the Joxin, you should know about it and bring up. But I think you laid out nicely in this program, the community, the conversations we need to have, and what people should know as the baseline.
Yeah, yeah. Now we talked about that this is heart failure is something where there is fluid accumulation. Talked about the swelling of the feet, so therefore there are patients that are on diuretics, water pills. So let's
Oh
talk
yeah.
about sort of when that's part of the another drug that maybe is in that treatment regimen, right?
Yeah. Correct. All the drugs we've been talking about so far help with all we do in medicine. All we do is try to make people live longer or feel better, right? If you remember the whole heart failure thing, we were talking about not getting enough blood out or congesting a little bit too much. Diuretics, factor in there. Diuretics are not going to make you live longer, but it will make you feel better,
Right.
right? As a matter of fact, what it does is all that congestion that builds up and it's hard for the heart to circulate all that. Well, when you finally do get the blood to the kidneys, diuretics just tell the kidney, hey, pee it open. Just pee it out. You don't need all the salt water, just pee it out. And by doing that, you relieve a lot of the congestion right away. And then, people feel better because of that. You can walk more because your heart's not struggling so much to get the fluid around. But then the couple things about that. If you're peeing out, you may be peeing out too much potassium. Your electrolytes, the salt water, and all that kind of stuff get thrown off. It changes the kind of medications in your blood because you can pee out some of the medications you do need. But one more big thing is if you remember the problem with that whole RAS system, I keep harping on that today, but the RAS system goes off because the kidneys think you don't get enough fluid.
Right.
But now you get diuretics, which make you pee out more of that fluid. So you're going to set off the RAS system even more. And it's crazy. It's a cycle. But that's where we call it the art of medicine. And that's why we call it practice. Everyone's individual. Sometimes they need diuretics. Sometimes we should pull back. Since we know it's not going to help you live longer, just feel better, we kind of have to balance all that. And you all, listening to the program really need to know where this factors in.
Yeah. So as you know, I've been doing this a long time, and I think that the management of heart failure really is an art,
Yeah.
because it's not a one size fits all. Everybody is
Definitely.
very, very different. And so if you do
Hmm.
have heart failure, most patients, I think, are being seen by cardiologists by and
Hmm.
large for the management of heart failure, as opposed to primary care providers, at least till they can get their drugs figured out, figure out the
Hmm.
perfect combination for them, and then after that, it's a little bit easier for the primary care physician to manage. So I
Yep.
think that if you're
And
out there and you don't have a cardiologist and you're not doing well with your heart failure, you're going to the hospital over and over again, readmissions, relapsing, you need to seek some specialty care. I really think that that's
mhm.
important. I really do.
Exactly. I mean, you're right on point, but you're so on point that it actually is even a deeper level within cardiology. There are cardiologists now who all they do is heart failure because it even gets beyond medication now. We actually now get into situations where we try to take the heart and we actually change the electrical flow through it, things we call cardiac resynchronization therapy. Sometimes the heart function drops down and you're at risk for suddenly collapsing. Those people you hear about who go to bed and don't wake up, or they're
Right.
suddenly talking and suddenly falling. That's a big part of heart failure. And so in those times, we'll put in things called defibrillators. They won't make you feel better at all, but you'll live if you ever need them to get shocked. There are a
Right.
couple of other drugs out there, Ceralaxin, and we can go on and on. But it actually does get to a point where two main things need to happen. You can get so bad, all of our medications aren't working. Nothing is going to make you feel better. You can get to the point where standing up off a couch is too much for you. You're very short of breath doing that.
Yeah.
We may be able to at that point put catheters, little tubes in your chest to see when the pressure builds up and not. We can suck blood off. We can suck fluid off. It may get to a point where we put these almost like dialysis into your body and put that through around like kidney dialysis and get some of the fluid off. Finally, it may get to a point where you need a heart transplant, and not everybody has the same kind of match for other heart people, and not all hearts will fit. And so it may come to a point where you have to consider, do you want a heart transplant? Do you want to be on a list for a heart transplant? Or should we kind of work on palliative therapy? Because heart failure itself is not a diagnosis. The cause of heart failure is the diagnosis. But once you get heart failure, you'll never go back. It is a
Right.
progressive disease, and it's with you forever until you can't, until it actually overcomes you in your
Right.
system.
Right, but there
And
are
so it's
some
pretty
some
sad.
healthy things you can do to sort of help the medicines, right?
Yep.
So healthy diet, decreasing the
Yes.
salt in your diet. You said quit smoking. You said that earlier. Trying to get down to a good body weight, right? In terms of not being
Please.
obese, right?
Correct.
Overweight. So your
Correct.
BMI, we would love you to be a BMI, body mass index, less than 30. Um, you mentioned sleep, right? Getting your
Mm,
rest, right? If you have
yes.
snoring or sleep apnea, you need to get that looked at and checked.
Hmm.
So, there are some things to help it's not just about the drugs. You need to also
Absolutely.
change some lifestyle behaviors in order to help
Yes.
your cardiologist make you feel better, as you were talking about, right?
Absolutely. That exercise definitely. And to your point about BMI, that is so huge. But the excuses sometimes you hear in our community may be that oh well, I'm big boned. Or, all right, I'm like, I've never seen a fat skeleton, so that never matters. Or, hey, that's for those people. That doesn't matter in our communities. Well, guess what? These BMI numbers do matter, no matter what you are. Yeah, you can have high BMI because you're very muscular, but again, we're talking about the heart having to pump through a lot of pressure, and if your BMI is high, like you're saying, your heart has to pump through a lot of that. Number two, if you're already bigger, you can save a lot of water. You can be congested a lot before people pick up on it.
Right.
Well, that's just letting your heart progress, further and further to the point where it's really hard for us to fix things, or at least
Exactly.
help things get better.
Yeah,
So
so
yeah,
so speaking as a
great
person who has
points.
had to struggle with my weight my entire life, the only big boned stuff that black folks need to worry about is them big bones of ribs they eating too much of. Okay, with the barbecue sauce on it. Them big bones
Oh
are the
yeah.
ones we need you to cut back on, right? Yeah. Otherwise, weight is weight, and we all have to struggle with it. I know I do. And so it like right now I've started, New Year's resolution, we always get going in January, so I'm going to get 40 pounds off. That's my goal. 10 pounds a month. Next 4 months I can get ready for bathing suit weather in July. And they promised
Nice,
me that
nice.
hopefully the country will be in better shape come July. I'm hoping on that, right, in terms of COVID.
Oh
So,
yeah.
but
Oh, it
I just
should
want to
be.
thank you. This has been a great discussion. I think we really did a deep dive into heart failure and its management. Any parting words you'd like to tell the audience as it relates to heart failure?
Well, just two things. One, you make it very easy because you know all this stuff. I could just kind of bounce off of you, being an authority you are. So thank you very much for letting me come on. And for the rest of the listeners out there, if you get nothing else from this, the biggest 2 points are, would be that one, there's a reason for everything that we do out there. We can only try to make people live longer or feel better. But and these medications all have a role. There's a reason for this. But then the second part is based on what you've heard today. You need to bring these discussions to your doctors, and if you're not satisfied with the discussion, have a longer discussion. And in today's world, Dr. Coleman could probably set or talk about this at a later time. But in today's world, it's very hard to get across all the stuff that we want to say in a 15-minute doctor
Yeah,
visit,
yeah,
mostly because our doctor visit has nothing to do with the doctor patient anymore. It's a lot of extraneous stuff. But if you're not satisfied, you may need to get in a situation kind of like what we have, which is a concierge situation. We'll sit down and we'll talk to you. It'll take as long as it takes. We'll call you at home and such. The bottom line is wherever you are with a doctor, you got to feel comfortable. You got to have these discussions and you got to see how they all go together, as Dr. Coleman shows all the time with hypertension, diabetes, cholesterol, heart failure, and such. So thank you for letting me get on here and thank you for letting people know about what you're doing. Healing Our Village is powerful. And I think more and more of our listeners should just be part of it just because, you fill in a lot of blanks that people don't even know are there.
yeah. No, we're really proud of what we're doing with For Your Health, and this actually is, like I said, up on my website, HOVHealth.com. It's going to be
Hmm.
also broadcast on Black Doctors
Hmm.
.org, and then this is every Saturday. We try to come to you with at 1 o'clock with For Your Health with some kind of important health topic. And then you can just, if you miss it, that's okay because you can view it at a later date. But I'm really happy. The reason that we started For Your Health is because I've been doing, education for the last 40 years, and I would have a class with, 10 people, 20 people, and, there's 30 million people with diabetes in the United States, right? And we have all these people
Absolutely.
with heart failure and hypertension,
Hmm.
and we just got to do it. We got to reach more people with
Sure.
accurate information. So, you're in my kickoff here. I just started For Your Health about a month ago, and so I really appreciate you. We're going to send you
Good
a
deal.
copy of this so you can show it to your patients, yeah? And put it
Thank
up
you.
on your
Thank you.
social media so that you have it. So again, for those who are watching, thank you so much. Any questions? We're here for you. 800-788-0941. Give us a call. We have something called Village Club, very much like your concierge medicine, where you would actually have your own pharmacist, your own dietitian, your own
Perfect.
medical experts. So again, go up on our website, HOVHealth.com, and take a look at all of the activities and services we have up there. Thanks a lot. And again, this Saturday, 1 o'clock, tune in For Your Health.